A warm welcome to everyone joining us today. People from 45 countries have come together across the world. And the reason is obvious. We have a moral imperative. If we want to achieve the goals that are most important to people and their families, we can no longer support health and social care systems that are not integrated, that function separately. Because in the eyes of people and their families, the hope and dream is that our health and social care systems are connected and focused on what's most important to them. If COVID has shown us anything, a global pandemic, it is the importance of working together across our health and social care systems, focused on what's most important to people and families. The moral imperative is that integration provides an opportunity for equitable care across our entire regions, locally in our communities and across the world. Today's session is being brought to you from one of the International Foundation for Integrated Care hubs, our hub in Canada, which is the first North American Center for Integrated Care. It is brought to you today by IFIC Canada, which has been co-founded by myself, Jodeme Goldhar, and Dr. Wodchis. I am the treasurer of the International Foundation for Integrated Care and co-founder of IFIC Canada. I also serve as a strategic advisor to integration, many opportunities around the world, but the one I'm incredibly proud of is a strategic advisor at Ontario Health for Ontario Health Teams, which is Ontario's vehicle for integration. Today's session is focused on workforce capacity and capability, and people as partners in health and social care. And it really is two sides of the same coin. If we want to co-design our health and social care systems and partner with patient, clients, caregivers, then we're also looking at the opposite side of the coin, which is developing new skills and capabilities to make this happen. Today's session will be about that. Walter, please say hello to everybody, and then I'll introduce our panel.
Excellent. It's such an honor to be here today. My name is Walter Wodchis, and along with Jodeme, co-founder of IFIC Canada, I'm a professor at the University of Toronto and a research chair in evaluation and implementation science at Trillium Health Partners, one of our health systems here in Canada. We really have a fantastic panel today. And it's an honor to be here with you and with this fantastic panel. You know, we're climbing to the top of the IFIC knowledge tree. If you're not sure what the IFIC knowledge tree is, you can look that up, Google it. Up there, we find people as partners in care and workforce capability and capacity. And these are fundamental to the success of person-centered integrated care. Patients need to be involved to define the problem and needs to ensure the right problems being solved for. They know what their needs are. People who need help managing their health need to help identify their personal goals alongside providers. And so providers need to understand how to work with patients to set goals and plan care that supports these goals. The complexity of people's needs are increasing. And as this is happening, support for coordination of care and access to services such as dietitians, pharmacists, social workers increases. And managing access to a diverse array of needed services and ensuring information exchange are two essential characteristics of integrated care. The skills of coaching patients and coordinating care services, or at least providing information about available services, has emerged as an increasingly important role, given the increasing complexity of individual needs and available services and service providers. In some health systems, such as Casa Plus in Germany, they've created an entire college credit program to train care coordinators. The workforce needs to adapt to meet the changing needs of patients. Today, with our panelists, I suggest that we challenge our patient participants to help demonstrate not only why patient engagement is important, but what it looks like when it's done well. And maybe in the audience, you know some possibilities where things are being done really well, and you can put those in our chat and share with each other. We can challenge a workforce panel today to provide advice for how new emerging roles can be connected to existing health and social service providers to actually enable the delivery of integrated care. And again, in the audience, are there people that are doing this well? Do you know of opportunities where it's doing well and you can share? I'm really looking forward to our discussion and to your contributions. Back to you, Jodeme.
Thank you, Walter. The panel we have today through IFIC Canada was designed to look at multiple perspectives. You can see the incredible array of expertise. The first is Philiz Go. Philiz is an oncology nurse and recently completed her master's. Philiz also had an acquired brain injury, and through that process, got to understand our health and social care system in Ontario through a very different lens. She has now partnered with IFIC Canada to not only co-design this session, but co-design the conference we are bringing to Canada and to North America in the fall. Look forward to talking about that. We also have Christa Haanstra. Christa is a transformative leader and really on the precipice of the most emerging knowledge around how to build capability and skills to co-design in local communities, working across health and social care providers in partnership with patients, clients, and caregivers. And Dr. Kerry Kuluski is a research chair in exactly this focus. So you can imagine both the experience of a client, a patient who also works in our health and social care system, somebody who helps local communities build the capability to co-design the answers, and then an extraordinary person who does research in partnership with patients and caregivers to understand how we bring out the value in our local communities and more globally to enrich how we design and deliver on integrated care through the lens of patients and families. A warm welcome to Philiz, Christa, and Kerry. To start this, Philiz and I are going to have a conversation. And as Walter had mentioned, for those of you that are out there listening and responding in 40 plus countries around the world, please make the chat active. We want to hear your thoughts and reactions. We want to learn from you as much as we share. This is a growing field and skill and capability. So join us in the journey and be interactive with us. Philiz, let's start together. The goals of the session were set up very particularly so that we focus as a panel, but also that the people participating today understand clearly what we were hoping to achieve through this session. And the first is to garner an understanding of what it means for people to be partners in health and social care, and how is that different from the way our health and social care system is generally designed, which is non-integrated or non-connected up. Philiz, to you.
Well, to be genuine partners in health and care and to be different from the current paradigms of care, we need to incorporate and embed the patients' and caregivers' voices as part of the decision-making and truly listen to them about their needs, anxiety, and concerns. The patient and family will have to do their part in communicating their expectations and care goals. For example, when my father was palliative, there was a trade-off when having more morphine and a lower level of consciousness versus less morphine and being more awake was being decided. Often my father did not have pain, and we requested to have the pain medication on a PRN basis when he only had pain. We felt that there could have been better communication and working relationship to clarify goals of care so we could be more aligned as they were providing pain medication on a standing order. It is also essential to anticipate or determine the patient's or family's needs and or functions, and if they need support during the patient's illness. With my brain injury at the onset, I was not able to care for myself. Although I looked young and independent, I had difficulty caring for myself. And with my brain injury, I had trouble communicating that I needed more help. With all the healthcare providers that I worked with, I do not recall anyone asking me if I lived by myself. I ended up having to struggle for the first few months, not knowing that I had to eat, unable to walk safely to the bathroom, forgetting to wear pants when I went out. It was a disaster. Asking if patients and caregivers need any support at home or have any financial concerns can make a difference. Having to deal with a health concern is already stressful. So if health professionals can help unburden them with their other stressors in their life by connecting them with resources, this will help significantly with their quality of life. One good example is the physiotherapy clinic that I went to for most of my traumatic brain injury therapy. I had a physiotherapist, an acupuncturist, a massage therapist, and an aquatherapist. All of them communicated with each other and had meetings about my goals and needs. If I arrived at my physiotherapy clinic totally nauseated from a taxi ride there, they would know how to position me on a bed to rest and communicate it to the therapist to reschedule my therapy for that day. It was reassuring to know that when I got to clinic, everyone knew my special needs and goals for care.
When I listen to Phyllis, and I'm sure many of you are thinking the same, when we move the emphasis away from what each part of our health and social care system provides, or what we provide as clinicians and what we've been trained, and reorient to the individual person and their family, or when we think about an entire population around either an individual person's goals or a population's goals related to health and wellness, the way to achieve that is when we work together across a system focused on what's most important. Sometimes, or often, unintentionally, we miss the mark. And that is why the partnership together helps us realize what the potential is for integrated care, both at an individual level, but at a system level as well. Phyllis, I understand, or we understand, that new roles and competencies are needed to do this work. Can you tell us your perspective based on your experience, what this looks like?
Well, it would be helpful if there were more nurse navigators in various disease sites to help navigate patients within the respective health system. For example, in my case, I was lost when I was diagnosed with a traumatic brain injury. I did not know who to approach, what resources were available to me, what to expect in the sense of symptoms or appointments, and how to connect with other health professionals. It would have been helpful to link with a nurse navigator from the beginning who would help guide me through the process and help answer any questions that myself or my family had. It is very overwhelming being a patient in a vast healthcare system, and we get worried we will get lost in the system, let alone having a brain injury and not having all your faculties working. It is quite frightening. Helpful competencies for health professionals to have would be listening and communication skills. Building trust and rapport with a patient is critical in developing a relationship with them to help them in their journey. Also, having the skill to ask valuable and helpful questions that can directly benefit the patient. Example, if they have any financial concerns. Communicating interprofessionally is also essential for patients and caregivers, as it ensures that health professionals can share information about our care correctly and without bias. Knowing how to chart is also helpful for patients and caregivers, as I've seen some potential errors in my chart. I've also witnessed bare minimum dictation that did not capture other aspects of the patient and health professional interaction that may be significant. It would also be helpful to have health professionals follow up with patients and caregivers. Following up would help close the loop, but also continue to build rapport with each other.
It is obvious that despite best intentions, when we think about the lens as a patient experiencing what we do, what those that work in health and social care do, and how it's connected up, we could actually solve for some of the greatest pain points by listening and working together to resolve what Phyllis has given examples for, and there's many others. Some of these examples are not complicated to solve for, but one of the biggest shifts is creating a shared purpose to solve for them together. And the vehicles for integration, and they're different around the world, In the UK, for instance, it's the Integrated Care Systems, the ICSs. In Ontario, it's Ontario Health Teams. Regardless of the vehicle, the intentionality is to address the moral imperative. What is most important for individuals, and how do we get at health and wellness from a population perspective? And the only opportunity really is through integration. Philiz, share with us then how patients and caregivers become partners.
Well, having patients as partners in care changes the landscape of the competencies required to deliver integrated care for patients and health professionals. So empowerment can be helpful for patients, along with necessary tools to afford us the means to better advocate for ourselves within the healthcare system. Tools such as online webinars or courses, in-person training, and supports and resources to call if there are any questions to clarify. All of these need to be free and fully accessible. For health professionals and anyone who has to connect with patients and caregivers, including porters, cleaners, medical administrative assistants, volunteers, etc., need more intensive training on how better to communicate, listen, and implement integrated care values into their daily practice. It would even be better to embed integrated care into our education system for all health professionals and roles in contact with patients and caregivers. One possible approach is to include a mandatory course. Suppose we can get the majority on the same page with similar values and provide care and services that mirror integrated care. In that case, the partnership between patients and caregivers will only get more robust, and fewer patients will be falling through the cracks.
Following our session today, we will be announcing the conference in Canada, and it is a partnership and has been co-designed with patients and caregivers. And as a result, building on what Philiz is saying, it is open and accessible and free to all patients, clients, and caregivers around the world. And the reason is exactly what Philiz is saying now. We can't just speak to this. We actually have to close the gap on what we say we're going to do and what we actually do. And we will talk more about it later, but building on Philiz's comments and the fact that Philiz and Carol Ann Alloway and others have helped co-design the conference that is coming, the lived experience is includes an equal partnership in the entire conference. Philiz, the last question for you is provide examples of how integrated care delivery systems enhance the skills and bring new roles from multiple perspectives when we're thinking about it from a system lens, an organization lens, and the front lines.
Well, we speak to how we need to engage the patients and caregivers at the point of care across health and social care organizations at system level. We also speak to how developing new systems of care requires new roles, skills, and capabilities on health system providers and patients and caregivers to engage in co-design and implement new delivery models. An example that did not work well was how it took quite some time for referrals of specialists to occur in my situation. Not knowing which specialist I needed to see was also an issue, only to find out years later suffering from symptoms that a referral to a specific specialist would have been helpful but was not offered. Moreover, the specialists did not work with each other to help care for me as a whole, and there were no team meetings to discuss my goals or needs. An example of an integrated care delivery system that enhances skills and brings in new roles is Sunnybrook's Breast Cancer Center. When I was working, a nurse was explicitly hired just to care for mothers diagnosed with breast cancer with young children. She would follow them through their treatment trajectory while also providing tailored resources to assist them with their needs, such as nannies to help out at home that was free for a certain number of hours. This nurse would manage the patient's side effects, be the link between patients and the physicians, and coordinate all the appointments around the patient's schedule. By having integrated care delivery systems, we will be able to enhance the communication between patients, caregivers, and their healthcare team, which will improve the overall care being provided and hopefully help make the healthcare system more efficient in delivering care.
Phyllis, thank you. So the imperative to all of us, and I believe we have many clients, patient, caregivers on the line, as well as not only 42 countries, but people who work in policy, research, organizational leadership, frontline across health and social care, innovation, technology, academia, the works. And when we all think about it, it comes down to a common shared purpose. What is most important to individuals and their families at an individual, at a community, and at a societal level? Phyllis, thank you so much for setting the stage. As we turn now to an expert, somebody who is on the leading edge of the world research around how to do this in practice. We can hear about the idea to partner, not share information, but actually partner, where we share power with patients and caregivers to design our systems. I'd like to welcome Christa Haanstra to share her experience. Christa. You're on mute.
Hi, everyone. It's a pleasure to be here today. I'm Christa Haanstra, Principal of Clarity Hub. We've heard already a lot about integrated care and that it requires true partnership with people, patients, caregivers, professionals in a variety of disciplines across all the organizations that cover the continuum of health and social care. At Clarity Hub, we work with teams to coach and guide them to bring their commitment to engagement and co-design to reality, really taking that step from their intention and their vision into implementation. And we see that there's a big chasm between intention and implementation because exactly what we're talking about today, which is that the workforce requirements and the skills that are needed are fundamentally different than what we're used to in planning in organizations. We see that really big commitment, but we really see the inability to move the first step forward into implementation on meaningful partnership. Really, it requires a fundamentally different approach to strategy, planning, resource allocation, expectations for timelines, the role of each person in the process. It really depends on skills like being comfortable with ambiguity, being creative, flexible, adaptable, being able to listen, really listen, as Phyllis already talked about, to understand before leaping to outcomes, next steps in the process. And as Phyllis also explained, to do this and to truly embrace this approach, you have to collect, understand, and analyze all the quantitative metrics, but marry that very clearly with the qualitative insights, understanding the experience of everyone involved, the patients, the family caregivers, the providers from a variety of disciplines, the organizational views. And we know that that is a subjective process and isn't always easy. So the idea, what we experience when we're working with clients is that they've done this very, very deep quantitative analysis. They look at the metrics, all those things that have been measured, but the emphasis on the qualitative side and the experience side of things sometimes hasn't even been done, or if it's been done in a very light way. So in order to make that meaningful change and create true integrated systems, you need to understand the current state from all the angles and a patient's and caregiver's experience of the exact same situation is distinctly different than the provider. So as Walter indicated earlier, you could be solving for a problem that doesn't exist if you don't have that full understanding. So we know that in organizations right now, we look at a longer term planning process. And so the idea of making assumptions can be really challenging when you're committed to engagement and co-design. So in many ways, it requires a bit of a leap of faith. You still have to create those assumptions in order to do the planning and the budgeting and the resource allocation, but there has to be buy-in from the senior levels and across organizations such that the budget and the resource allocations can be adapted to reflect what you're hearing through the process. And that has to happen without criticism of the planning process, because it really is part of the process. In many ways, it's that tension between being able to plan and think ahead and being flexible enough to adapt and pivot midway through the year as the understanding of the situation changes. One of the things we hear a lot in the co-design and engagement process, which is a hesitation from organizations and professionals, is that there's a fear of criticism of how things are being done right now. And that is we see a lot of hesitation of people coming to the tables or to the meetings or to the discussions with that openness. And I think it's really, really important to think back about what we've already heard today, which is that I've yet to meet in my 20 plus years of working in the healthcare profession, I've yet to meet a healthcare professional who actually comes to work wanting to make life difficult or hard for patients and caregivers. It's simply not the reason why they got into the field, and it's certainly not why they want to go into work every day. It's the structures, it's the accountability metrics, it's the unrealistic timelines, it's the fear of telling a funder that they need more time or that their plans have changed. And those are the reasons, those are the things that we need to look at through an engagement and co-design process. It's not about the people in the roles, it's about what we're asking them to do and how we've created those structures, policies, and procedures and approaches that have created these disconnects. When I think about Phyllis's example of wanting a navigator, I take a big step back and say, we shouldn't need navigators. We should be creating systems and experiences and opportunities for people to be able to interact with their healthcare that's intuitive. So we often default to navigators because that doesn't exist. But imagine a world as we go forward that doesn't require navigators. That should be our ultimate goal, because people can work through the process and can intuitively know what's coming next and have access to their healthcare information. I'm not going to talk about digital and healthcare online EMRs, but that's a whole other piece of this puzzle that would make things come together. So in summary, when we think about workforce and people as partners in care, there's an incredible connect between the two. We're asking our workforce to approach change and improvement and developing new processes in a fundamentally different way, and taking a fundamentally different approach to planning, resourcing, and budgeting. We're also talking about relying on skills such as creativity, adaptability, as well as coming to meetings and discussions, recognizing everyone as equals in the process and respecting patients and caregivers as experts in their own right through their lived experience, and valuing experience and the qualitative metrics as much as we value the quantitative metrics. It also requires people and organizations to be bold and brave and to be willing to speak truth to power. In many cases, funders, government, and others that health and social agencies are accountable to. And to bring people along that journey often requires a leap of faith, because you may be saying to your funder or go back against your agreement to say, we aren't actually going to take that approach. We need to take a different approach because we've heard through our co-design and engagement process that we need to focus on a different issue. And finally, I would say it requires policy and funding guidelines and agreements and governments to reflect on the commitment to this approach. And this is how we're asking health and social care agencies to go forward to create an integrated model. Then we need to look at how our policy and guidelines are created in order to allow for that flexibility and adaptability, because we see in many cases with our clients that there is a feeling that they cannot go back and go against the commitments that they made a year ago to those funders and and to the government. And although I'm not covering this today, I do want to reassure you that there's plenty of evidence that exists that this approach works. And on that note, I'd like to turn it over to Kerry, who's going to talk about this in the context of research and academics. Thank you so much.
Thank you, Christa, and good morning, afternoon, and evening to everyone today. It's so great to be here. And I bring a research perspective, but what I'm going to say is also really relevant to policy and to practice. And I want to focus on 3 types of shifts that I think we need to make to really start to understand how we can work truly in partnership with patients and care partners in what we do on a day-to-day basis. So first, I'm going to talk a bit about a paradigm shift that needs to happen so we can focus on, our assumptions in the day-to-day work that we do. Then I'm going to shift and talk about the power shift that we need to be mindful of as we go about our day-to-day work. And then I'm going to move into a learning shift and focus a bit on how we can start to shift the way in which we're approaching research. So with the paradigm shift, even though there's multiple paradigms and worldviews that guide what we do on a day-to-day basis, we're really constantly pulled towards this kind of expert paradigm of provider knows best, or researcher knows best, and we're predominantly trained to have the answers, to have our checklist, to know what to do and to follow the steps and be rigorous. But really the person-centered care model is pushing us more towards a critical paradigm to share knowledge and to really work together to figure out what directions do we need to move in. And so, as I noted, this paradigm is not new. If we look at community-based participatory action research, that's been happening for decades. And that's when communities and people and citizens identify, these are the issues we're having, and we want to improve how our community functions. And they partner with researchers, they partner with policymakers to advance, their systems and make them better functioning. In our healthcare system, in more of the traditional sense, that kind of concept of partnership is still a bit new. We're still trying to figure out how we can authentically kind of work against the grain when we're pulled to have the answers and be efficient and in our day-to-day work. So there's tons of examples around the world of what it looks like when we're working in partnership with patients and families, but it's still, we still have to work against the grain in order to make that happen. And so we have to ask ourselves, when we think about knowledge, whose knowledge do we actually value? Do we think about a researcher's knowledge base and a clinician's knowledge base, a policymaker's knowledge base being equivalent to a patient's knowledge base? So they're experts in their experience. And when we start to think about how we can equalize and honor all these different types of knowledge, then we can start to see that everyone has a piece of the puzzle. And as we know from Philiz, she wears multiple hats. She was an oncology nurse. She had experience as a patient. That painting behind her, she painted that. She's an artist. We all have multiple roles that if we come to the table as ourselves without automatically jumping into I am a researcher or I am a oncologist, it opens up the space. And that brings me to the shift around power that I'd like to touch on. Coming together to work together often for the first time, it can be really scary and really intimidating because we hold in ourselves different levels of power that we might not even be aware of. So as researchers, if you're doing qualitative work, we're trained to be reflexive, to try to be aware of how we're making others feel and what we do. But in other types of research, that might not be as much of a focus. So when your work is relationship-based, when you're not aware of how you're coming across and if you're creating an open space to have dialogue, it can be really intimidating, and it could shut down a conversation. So patients and family partners have said to me and to others that we need to do some pre-work before bringing people together to learn how people want to engage in that process and if they want to tell their story right away, because it could feel traumatizing to have to retell a story that's been really difficult in the health system over and over again. So how to create those open spaces and honor where people are at and how we can come together in a way that feels safe is really critical. And finally, speaking to the knowledge shift. So, in our experiences as, I'm speaking to researchers out there, we sign up for a program and a bunch of courses and we're often trained to do something in kind of independent. We might do some teamwork, but really we're trained to be really efficient solo researchers who are very skilled in a particular area. Even when it comes to qualitative research, we're skilled on how to do interviews, how to analyze data. But when it comes to patient and family partnership, it requires a different set of skills. And at the Institute of Health Policy Management and Evaluation, I'm really excited that we've co-developed curriculum with patients, families, and the community to train health services researchers with patient partners how to do this work. So we're actually, this gets to the kind of the workforce side of things. How can we prepare people to be comfortable in doing this work? And so we are basically walking through different stages of the research cycle, from setting priorities to evaluation to methods, assessing impact. And students are learning from patient and family partners what that looks like, what impact means to them, and how to actually go about doing that work. So, and I think as well for clinicians, policy planners, there's lots of great learning that we could all do together to figure out what this looks like. And it speaks to, what Christa was talking about with being adaptive, having that open mindset to shift course if we need to check in to see how things are going, and make those necessary adaptations instead of being really rooted into what we do. But again, we're kind of embedded within our context and within our paradigms that kind of create a bit of a hold on how much we could adapt. So we are working against the grain, but I think as we start to shift and work more towards more of an equal partnership with patients and families, we can start to see the benefits of that. So I'm going to leave it there and pass it back over to Walter.
I think I'm going to step in for a second first, Kerry. To Kerry, Christa, and Philiz, thank you so much. The first reflective piece, if there was a summative, is convening integrated care requires new power, where we shift from where a few people hold the power and make the decisions to a shared power paradigm where we share power for decision-making and creating our new systems and models of care. And that holds true no matter your lens. And we heard it from three very important lenses. That of a person, Philiz, who not only works in our health and social care system, but has firsthand experience as a patient, along with her caregiver, her mom, Elizabeth, who we work closely with as well, to Kerry as a research chair, and to Christa, who is helping build capability and action. Walter, to you to generate a conversation with our audience.
Thank you, Jodeme, and definitely we have a couple comments coming in from the audience, and I'll just say for the people participating online, either on the live stream or through the portal, let us know your thoughts and reflections, and maybe you have questions that we can incorporate here. We had a couple, Anne Lawler from Ireland, talking about striving towards integrated care for a specific population around a gene deletion 22q11 and a lifespan care condition needing multidisciplinary approaches. And Anne actually has said needing to be a little cautious about whether we need navigators or not. Some of us will need navigators, which is a controversial point. Richard Lewanczak saying, totally agree that if we need navigators, we haven't designed the system or pathways correctly. And so thinking about co-production, Mandy Andrew really highlighting the importance of this, and Kyra Nabetta identifying the need to acknowledge the power dynamic in patient care, and that we're not always coming at it from the same level or the same approach. I have a question for our panelists that strikes me across some of the important components that you've mentioned. All of this takes time. And it takes a little more time than a busy provider might think they have in their day. And I know that we actually had a different session where a patient had said the other day that if she had a magic wand, the thing she would change is that she'd make more time. And that would be a very magic wand. But in place of that, we need to have justification for taking more time to ensure that we have stopped to understand the goals of care for patients, and we're working in the right direction, and that we've built the processes in place so that patients can have the engagement in their care. So I'm just going to go around actually to all three of you briefly, just to comment on that. How do you justify the time, and how do you prioritize the time? So Philiz, maybe I can go to you first, and then Christa, and then Kerry.
How do I justify the time for, sorry, say that again?
To ensure that patients are involved and engaged in the care, for providers to take the time, as opposed to just defining what the needs are in place of the patient.
Yeah, that's a tough one, because a lot of times the, like in our government here, they allot only a certain amount of time for physicians to spend time with patients. And we as patients have, and they tell, you know, for example, they tell my mother, oh, you only come in and have one issue to tell me today. But, you know, we don't usually go into a family doctor and say we only have one issue. We usually tend to have more than one issue when we go to a family doctor. And so it's a tough one. How do we make sure that we give quality care to our patients, and still, you know, spend time with other patients and also fulfill the government's needs with funding? So it's not just caring for our patients, we also have to worry about our funding. So it's come down to the whole government level as well, and how we balance the government funding and also the patient's care. So it's a whole system level that we have to really manage. And the physicians is the one that's kind of stuck in the middle, and also nurses, not just, or any health professional, to be honest. It's really tight with all about the funding. And you know, like nurses, we're in COVID time, we're totally strung out. It's really they're all stressed out with the amount of time we get to spend for our patients, with, you know, wound care and everything, but our patients we don't get to spend quality time with getting to know our patients and giving our quality care we need to our patients. Yeah. So it's really a fine line of balance with that. So I think it's a whole, we need to revamp and rethink about our providing more supports for our health professionals, and also more funding for our healthcare system.
Yeah, it's very, those points, and actually some other points now coming up in the virtual chat, resonating with that, and Karen Abetta saying, getting to know each other, patients included, takes time. To what extent are medical professionals specifically taught to listen? So that's for our next panel to keep in your mind. Christa, your comments on this justifying the time, and then Kerry.
Yeah, I would actually argue that it's kind of a shift in the time, because you actually need to invest the time up front to build the relationships and to understand the issue and to build the solutions. But actually, you will find, and the research shows, that the implementation is smoother and actually is sustainable when you use this model. So you're not actually redoing the problem, resolving the problem later on. So I would say in one case, it's a matter of really thinking about shifting the way we think about the investment of time. And then I would say, the second thing I would say is that when an organization is beginning its commitment to this approach of building integrated care through co-design and engagement, there is a buildup, and there is a kind of a beginning stage where you need to build this capacity. But over time, it doesn't take more time. It's at the beginning when you're really trying to create those, again, the skill sets within the organization, building the relationships. Those things take time, but over time, it doesn't take more time. So it is really about thinking about it as an investment.
Kerry, anything to add to that?
Yeah, no, I agree, Christa. And I think if we think of any relationship we have with any person, whether it's clinical or your friends or whoever, when you're first getting to know someone, it takes time. You're trying to figure each other out and seeing, you know, if you want to hang out or not. And I think if we think of a clinical interaction or any kind of partnership as the same thing, you start to learn about each other. And to Christa's point, over time, you could just kind of jump in. You don't have to do that initial foundational relationship work. So if we think about it as an upfront investment that we will have to take the time. But then with us, when you have a common team who knows you, we heard about the importance of that from Philiz, then we, that takes a lot of, it gets a lot easier and smoother because of that. So continuity of care, upfront investment, and trying to match people to the right team, because it might not always work as well.
Yeah, thanks for those. Caroline Alloway saying, sometimes it's difficult to be a patient partner because we want to be a team player, but all of us, they're also critics because they're advocating for patients. And so it sometimes can be a dual role. And I think there's a couple more comments from Sabine, Isan, and Lawler supporting this, taking the time, and that being really important. There was a bit of a conversation between it's either Kira or Kyra, Nabeta, and Charles Zhu around some challenges that patients will have as they are in compromised health sometimes, and advocating for themselves can actually be challenged, and providers needing to be able to create that space and time in order to be able to do that. And I've got one other piece that I think comes up relatively often, and it's a challenge for providers as they become more patient-centered. It's easier for providers to ask about the one thing they know they can do something about. It's the old carpenter with a hammer question. So if I ask a patient and we find out there are things actually that I am not personally the most skilled or able to manage and take care of, then they're afraid of taking that risk because they look to solve problems, and they might be identifying problems that they don't feel capable to solve. So maybe we'll go backwards and just see if that's come up for you, Kerry, Christa, and Philiz, maybe if you have a comment after, and how you might think about that.
So I think of two things. I think of vulnerability, and any Brene Brown fans out there, I'm certainly one, admitting when we don't know, and admitting when we need to rely on our team. So it's important to have a team that you can rely on, because I think when we start to honor and understand each other's skill sets, we could then lean on each other to say, hey, like I'm not the best person. I want to help you. I'm going to bring in my colleague or my friend to help support us. And I think patients and families, needing to be comfortable with that, as well as the provider and the care team, because when you're in a crisis, sometimes you want that person to have the answer as well. So I can understand that. But I think, knowing that it's okay not to know and to be comfortable engaging in that conversation, that comes with having trust. It comes with having a longer relationship where you feel you could really disclose those things together. And it takes a bit of time to do. So again, teamwork and vulnerability is what I would emphasize here.
Thanks.
We saw this in spades when we were doing the caregiver work at the Change Foundation and doing the consultations across the province with providers, where the idea of knowing that the caregiver needed support and they could see it when they walked in the room, but not asking the question because there was absolutely no idea of where to go to help a caregiver. And that's changing here in Ontario a little bit, but it really is about the idea of not feeling like the professional had control or any ability to change that, and therefore just avoiding it, which was definitely something we heard in spades. And so the idea of an integrated system, I think, does help address this in a very notable way. And having the voice of patients and caregivers informing that would also make it go even further.
Yeah, Philiz, I don't know if you had anything to comment about providers being told things that maybe they don't initially feel they have the solutions to.
Yeah, so it's happened before to myself personally as a nurse, and I echo what Kerry and Crystal said about having a good team and being able to acknowledge that, yeah, you don't know everything, and that you have to have a good rapport with your patients and to tell them, you know what, unfortunately, I don't really know myself, but I can refer you to this person or to that person who may be able to help you. But to also realize that if that person is not able to help them, you just don't leave them hanging and be like, wash your hands clean and be like, well, I referred them and that's it. But to actually follow up with that patient and be like, hey, were you helped? Did you find your resources? And if not, then help them more and be like, let me look into it, let me research for you and look into that for you. So that follow-up, that closed loop that I was talking about, that's necessary, that's needed, because that's what I find that a lot of people, a lot of health professionals don't do. They refer and that's it, they wash their hands clean. And that's what's needed, is that they need to have that closed loop as well. So yes, so I definitely echo what they both said.
So clearly new ways of working in integrated care, which I think is a great segue into our next session. And I'll thank Sue Bukivase, who also said great session, so many important issues for workforce development and future training and existing healthcare professionals. Couldn't ask for a better segue, Sue. So I'll turn it now over to Jodeme and we'll on with our next panels. Thank you so much, Kerry, Christa, and Philiz for your real excellent overview, suggestions, thoughts, and inspiration.
I agree, Walter. That was so meaningful. And so is the dialogue happening in the chat. For you to be so engaged in this conversation, to help generate what is most important and how we're going to advance our skill and capability. I am
healthcare. We also see greater need for communication and relationships and integrated care delivery, and less need for kind of that task-focused skill set that you see in traditional healthcare models. About 5 years ago, I started working with Jodeme, as well as a few other colleagues, to kind of really dive into what are the competencies for leading integrated care. And we did some research. We analyzed a number of international healthcare competency frameworks for leadership. And we actually found that none of them specifically identified competencies for leading integrated care. So we did some work, we adapted the literature, we drew from our own experiences, and we identified what we believe are the 6 competencies for leading integrated systems. And I'm just going to quickly run through them, and I think we can post in the chat because we have a link to the article if people want to read more. But for the 6 competencies, the first is the ability to frame and reframe issues. So to help bring clarity to that complex or ambiguous situation that we find ourselves in often in an integrated system, and create a sense of shared purpose. Second is the ability to take the perspective of others and create a safe space for sharing, collaborating, and building trust. Third is having skills in that ability to co-design care with patients and caregivers at both the micro level and the macro level. We've heard about that from our earlier speakers. Fourth is, while we need to understand care through the lens of a single patient, we need to simultaneously maintain a system view, making sure that when we're making changes that we consider the impact across all the component parts. The fifth is sharing power, which we've talked a lot about, but essentially having leaders create space and supporting others to lead. And the sixth is being a reflective learner. So you need to be comfortable with changing and adapting as you go, taking risks, learning from both successes and failures, so that you can keep moving the bar as we build a more integrated system. So this work that we did on these leadership competencies, it's complementary to the research that Viktoria and Robin have done, as Jodeme mentioned. And the 4 of us have started working together to explore how COVID is changing the type of leadership that we need, including how we lead in a more virtual world. And through our initial research, we've heard, both good and not so good examples of leadership during COVID, but we want to learn from both. So you'll be hearing more from us on this, and we actually want to hear from you as well on how you see leadership evolving. So hopefully we'll have a good chat about that. That's it for me.
Thank you so much, Anne. And I'm sure the chat is starting to be active around your own perspective on what this means from what you've learned around the skill and competencies needed. We really are looking at shifts in how we can contribute in a positive way to help individuals, teams, organizations, and ultimately systems thrive when they are more connected. The language that I'm really appreciating around that adaptive space is the distributed leadership. Stop looking, really challenge ourselves around individuals who hold power to individuals who cede power to a collective. And in our distributed capacity, meaning across us, working in health and social care and in partnership with patients and caregivers, how do we have collective impact? Go slow to go far, move from individual to collective, which sets the stage for Viktoria and Robin. Over to you.
Okay, thank you, Jodeme, and thank you, Anne. Yes, and for my 5-minute contribution to the panel discussion today, I was going to try and reflect on what are some of the challenges that we've got to overcome if we're going to support our health and social care workforce to actually demonstrate these new competencies that Anne talked so eloquently about. And one of the issues, I think, when you come later on in a session is that some of this content you were going to cover has already been discussed. And I would just kind of pick up on some of the comments that Philiz made in terms of we need to embed this within our educational system. We need to think fundamentally about how we train, support, and develop our professionals in the future. I think as well, Kerry's points about in academia, it's not new to have a degree of silo working between academics, both in research and in terms of their teaching. So I think what I'd focus on is 2 other points. So those are in a way the institutional educational environment that we have that's an issue. The second thing I think is some individual concerns about professionals themselves. And when we look at what motivates people in their work, there's a few key elements to that. The first is that issue about purpose. So when we do our jobs, whether we're in health and social care or another environment, do we have a purpose? Do we feel there's a reason for doing what we're doing? And are we making a positive contribution to society? And I think most people would see integrated care and the aspirational vision that it sets out as being something that does give us purpose and that we can get behind. So I don't think purpose is something that's an issue. But I think the other 2 can cause problems for individuals. The first is the idea of mastery. So when we do our jobs, we want to feel that we're good at it, that we've got the right skills, the right expertise, and we're able to provide people a service or a support that's of quality and responds to their needs. And I think many of our professionals who spent many decades training to become specialists and experts in what they do, the notion of doing something different, of trying to be more person-centered in their work, or being more collaborative in their approach with colleagues can actually be quite daunting. And I think sometimes we don't recognize that actually can cause people quite a lot of anxiety. I know what I do and I'm good at what I do, but actually if you're going to ask me to behave differently, am I somehow going to fail in what I do? I'm going to let people down. I'm not going to achieve that sense of purpose. So I think we have to recognize that, yes, people might aspire to do it, but actually it can cause them a great deal of anxiety to do that. And we need to talk them through and support them. The second thing is that the other aspect that we often motivate us in our work is the idea of autonomy. So I have some degree of control over how I practice, which individuals or families I support, and the kind of interest that I have in my work. And again, I think from my research work, what I've observed is that often this is another element that can sometimes dissuade people from engaging fully with integrated care. If I'm going to become much more accountable to my colleagues from different professionals, if I'm going to be part of a multidisciplinary team, if I'm going to be more transparent in what I do and what I think to individuals and families, again, that's sometimes that people can resist engaging those opportunities because they worry that they're going to have less control and less influence over their work and how they practice that in reality. So again, that doesn't mean we shouldn't do it, but I think we need to recognize that people kind of really appreciate having such autonomy and talk them through about the benefits and how that does fit into the broader purpose. So there's a set of issues there, I think, about individuals. The other set of issues, I think, is a collective issue, and that's to do with our professions and our professional bodies. And I think we all recognize that professions is such an important element of our health and social care system. They help us to outline very clearly what are the requirements of people in terms of their qualifications, in terms of their expertise. It helps to ensure there's a minimum level of quality. It will also intervene if people are not providing a good quality level of support. But the other side of professional bodies is that people are socialized into a particular way of thinking and being. We know that when professions started, they were also a craft guild in which they were ensuring that these group of individuals would have access to a set of resources and a particular status in society that would not be open to others. And I think we need to recognize that professional bodies, although they're a fantastic element of our health and social care system, they can sometimes be a blocker in terms of people behaving differently. I think that's particularly the case when we're asking a profession to give up some of the scope of practice that would traditionally have been under their members and opening that up to other people to take on board those responsibilities. And to change professions, what we need is the people within those bodies to actually to highlight this, to say to our professional bodies, look, yes, we're very proud of what we do and why we do it. And we recognize the importance of maintaining our expertise, but actually we need to also see that collaborative care should be a core element of that. And it shouldn't, sometimes I think it's very easy for professional bodies to highlight this as being important, but not actually see it as being a mainstream requirement. I think it should be, if you're going to be a doctor, a nurse, a social worker, a physiotherapist, being collaborative should be a core competence. And I would even go as far as to say, if you can't collaborate, then you're not fit to practice as a professional in the 21st century, because we know this is what's required to properly respond to the needs of individual communities. So I would put it out as strongly as that. So that's the challenges. Now I'm going to hand it over to Viktoria, who's going to give you some solutions to those challenges.
Thanks, Robin. I don't know whether I can give you some solutions, but I certainly can challenge you and the audience to try out something new and something different. Hello also from my side. I'm sitting in very gloomy Vienna, but I'm trying to shine a bright light. And we've heard a lot of what needs to change and where we need to go to move forward and truly create integrated, people-driven systems. So I want to set it a bit in a global scale, on a global scale, and add some of the aspects that maybe haven't been mentioned so far. So yes, all of the speakers and all of the panelists have said we need to build trusted relationships, which means we need to create environments that are trusting and that actually support collaboration and honor collaboration instead of specialization and individualism. One of the key aspects here definitely is that we shouldn't cultivate in our professional education and training systems this feeling of, I am the expert, I am the specialist, I am the most brilliant of them all, and I'm the only one who knows the solution. We need to actually educate and train each and every one of our professionals, but also the managers, the supportive staff, administration, etc., and the policymakers to say, I am only one really tiny part of a big puzzle. And that puzzle is a healthy and well-to-do society. So this idea of health and well-being as being determined by so much more than just clinical care. And as we know, it's influenced by our social environments, by the infrastructure, our workplaces, education and training, etc. So this idea of health in all policies really needs to go throughout society and through all of the different systems that we're creating. So that's one aspect that we really need to step up and say, none of us can actually do this on their own. We need to collaborate because it's an imperative, as Jodeme said. We need to collaborate because that's the only way that we can provide health and well-being in the 21st century. The other aspect is really about, we need to acknowledge that health, social services, a lot of the supportive services are more than 70% female. And that means we need to create very different workspaces and very different environments for people to live and work in, and creating a different balance between work and family life. We are still very much working in organizations and systems that are male dominated, even though the workforce is very female. And that needs to be acknowledged. But what also needs to be acknowledged on a global scale is, if integrated health and social services are contributing to more equal, universal access to services, we need to acknowledge that high-income countries siphon away professionals from low and middle income countries, and in a lot of the least appreciated, worst paid jobs, we have migrant women. So if we do also need to value those jobs, the people who go into the houses and take care of the most vulnerable of our society are the ones that are most invisible, least paid, and least esteemed. So we need to take this appreciation of health and care professionals from the pandemic and really use that energy to change the systems for the better. But that also means that we as a society need to value health and well-being and all of those services so much more than just medical specialists. And lastly, I want to pick up on something that that Philiz said in the beginning, and that also resonated with me yesterday in another presentation of a person with lived experience, where he said, we're sent to different specialists, different professionals, and each and every one of them thinks they have the solution. But we are never asked, I'm never asked about my own feelings, my own needs, and my specialism. I am an expert too, and I'm a specialist in my own care and in my own needs. So this is something that we have to acknowledge, as Robin said, and other speakers have said, we need to actually have a communication between all of the professionals, families, and caregivers, as well as people with lived experience, on par, on the same level, and not think that one specialism and profession is better than another. And really embracing the idea that we are all human, and erring is human. We cannot have the solutions to everything. We cannot have the answers to everything. So really owning up to the fact that sometimes we don't know, and daring to say, also as a professional or as a policymaker, we don't know. That's why we're inviting you in. That's why we need to collaborate and co-design systems and services so that we have this approach as a much more emergent take on health and social care and health and well-being in more generally. So with that, I also want to challenge all of you out there to realize that you're all peers, you're teachers, you're mentors, and you are, the way you treat people is going to be reflected in the way others treat you, but also junior colleagues will replicate that, because that's representative of the culture that you're living in. So changing health and well-being towards more people-driven integrated systems means also changing the culture and the society we live in. And with that heroic vision, I'm handing over to Jodeme and Walter.
I really appreciate the final call to action, because it is about a shift in culture and behavior. And sometimes we refer to it as what are the fundamental shifts we need to make in mindset and behavior. And in order to do that, how do we build the skill and capability? It is critically important to learn, but it is important to learn by doing. And we have a call to action across the world about, and I've said it before, and I'm going to say it again, the moral imperative to reframe to what is most important to people, families, and communities, for us to look at building those skills around collaboration and breaking down the silos so that we have one collective consciousness. Sometimes it's a shift from, and this is a bit provocative, egocentric, where we focus on the training we've received as an individual, the organization we work for, to ecocentric, to people and families, and that we are here in service of something much bigger than our profession and our organization, but instead to people and their families. So Walter, with that, turn it to you. There is a very important discussion happening in the chat. Thank you.
Yeah, there are a couple of really important points coming up, both on the, and I'm a bit of a bridge here between the online platform and the conference and the YouTube chat. Both are active, and I think I give a one hand up right now for the YouTube chat over the conference attendees, but both, and we have some interesting and important comments. I just got to throw out there, fundamentally it matters what we value and what is valued, right? Which is social, a decision. And I think that's come up through a number of these. I'll say the audience has picked up on a few things, and I'm not going to go through them in the exact order they came in. First off, Robin, I think this was in response to your professional competency challenge around collaboration. Carol, really agreeing with you, so true. And then Anya also recommending and thinking about the transformative potential of reflective practice. And I know Anya's got some research. I was fortunate enough to be in her session recently, talking about some work that she's leading in that area. And she says that in that work, she's found that the terms reflective practice, reflexivity, and reflection often used interchangeably. And when they drill down, basically everyone's saying we're doing it, but the it is not clear. So she has a question here. What are your views about what is and how to do or undertake reflective practice? I'd be very keen on this because we're doing some observations right now with integrated care initiatives with a bit of an ethnographic approach. And our intent is to think about how to use this in a reflective way with the practices. So I could use your advice too. Maybe Robin will start with you and then Viktoria and Anne.
Well, thanks, Walter, and thanks, Anya, for an excellent point. And I do look forward to reading that research myself. So yeah, so and I would endorse the power of reflection to ensure that we practice it at the highest quality that we can. And I think for me, reflection has a number of elements. And yes, we need people to be reflection on a day-to-day basis in terms of their interaction, their kind of emotional connection with people, you know, their interactions with individuals and families, what went well, what didn't go well, how could they behave differently. But alongside that, I do think we need a very clear structure to reflection. We need to put in dedicated time in which professionals can come together, they can stand back, they can think about, you know, what they are doing, how they are approaching the individuals and communities, and to try and learn lessons from that. I think though, alongside that, I think there's a danger sometimes that we can kind of get a group thinking reflection, and sometimes professionals can come together and they're using an old framing of what their role is and what good looks like. So we need to make sure that we have a very clear set of principles that reflect current thinking, current aspirations of individuals and communities. We can perhaps use, like you said, Walter, some data to challenge what we're doing. So yes, you know, we might think we're doing a good job, but actually what we're hearing from people and families is that some element of that could be much improved. I think having interprofessional reflection is really helpful as well, because that brings in those different perspectives. And you know, I think as well, perhaps in reflection, we should have people's lived experience as part of that, because wouldn't that just open up a whole new set of opinions, of experiences, of challenges that would be so useful to our professionals as they try and reflect on what they do and how they can do it better.
Thanks. What is the problem we're trying to solve for? Viktoria?
I think that we actually need to teach reflection and feedback. I think very often people don't really know how to reflect and how to give feedback. We are not taught to reflect in a constructive way and in a structure, as Robin has said. The first time I ever came across how do I give feedback and how do I receive feedback was during my postdoc in a training for medical education. And I think that many people actually never receive that kind of training. So it's also about, it's another skill set really, but it's also part of the wider culture of how do we treat criticism, how do we reflect also on errors and which happen, and how do we have a quality improvement approach in general in our organizations, in our societies. I think another really helpful point would be, as one of the comments also suggested, is actually having patients, family caregivers, people with lived experience as part of your education and training, and actually them giving you reflections and giving you feedback, so that everybody really gets used to that kind of thinking as well. So there needs to be an educational shift, but I also think that we can be much more creative in how we reflect either in a group or individually.
Maybe Anne, from the practice setting closer to the front lines.
Yeah, I was actually thinking that whether we're talking about kind of reflective practice in clinical care or reflective leadership, it's really the same thing, is that we're encouraging people to be open to and comfortable to say, you know what, I don't know. We have this real blockage, I think, particularly in leadership and in clinical expertise, where people don't feel comfortable to say, I don't know. And so to be open to that idea of learning and feedback and being comfortable reaching out to other team members to say, you know what, I'm not really sure about this. Can you help me with this? Including patients and caregivers, to ask them their opinion. And so until we actually support healthcare through training for leaders, for clinicians, to really be open to that idea of reflective practice and helping people get past that idea that you're supposed to be the expert and it's not okay to say you don't know. I think that's a big block for us to really move forward in integrated care.
And again, just on integrating the streams, thanks very much for those. Kerry Kuluski from our own panel, I saw she got added in a little bit of a notion here that reflective practice, getting at thinking about what happened in a more of a past sense and reflecting on the past, whereas reflexive practice is being in the moment and awareness in the moment, and also understanding the power you bring and how it impacts others. And thinking about you're putting yourself in the shoes of others. And I think in terms of also a reframing of one's own perspective, Wilma van der Vlegel Brewer, hopefully I got part of that right, suggests, should we ask ourselves, do I have good news for the patient as the expert handing something over, or am I good news for the patient as a human with expertise? And I think it's all about presenting, like, how do we present together? And I think also Carol Ann Alloway identifying, nothing wrong with saying I'm sorry when things go wrong. And just being human and listening skills, and Lawler also asking about whether they get that capability and application. Earlier on, Anne and Carol, and I'll say Richard Levenchuk has also complimented IFIC for making this widely available to patients and caregivers for free, this stream here internationally in real time. And I think that's amazing. And we're also seeing patients and caregivers also jumping in here, Anne and Carol Ann, with quite an active chat. And I'll just bring in 2 or 3 of their points. Is it that the professionals don't have the right training, or it's highly voluntary? Interprofessional education might having voluntary training on being a good listener, but how many of the providers actually take that? And if it's not required, are they really bringing the right set of skills to bear? I think so. Caroline also says sometimes their experience is that healthcare providers see patients as weak or sick and not on an equal level, right? And they're in that solving. I think that also identifies a little bit related to another problem. I want to of the inequalities and coming in with the right perspective. I want to just with this particular panel also raise a couple of research questions, and I think there were a couple actually that came up. Charles Sue asked, maybe having more research to reflect the issues identified in cases that would become more important milestones in coming up with new treatment. So how do we study innovations that in practice and how they evolve, having more research in that regard. And Anne Hendry suggesting, and this, I don't know if this is more research or also just an advocacy role about what IFIC can do to amplify global voices and experience of social caregivers and family caregivers in practice. So is there a research component? So the first one being around, and you can take your choice maybe on which to reflect, how to use reflective practice in cases that would help identify those kind of new milestones in evolving integrated care. And the second thing being around how can we understand better the global voice of patients and caregivers, complimenting IFIC already for having made this available today. I don't know who wants to try first. Robin. Oh, Victoria. Go ahead, Victoria.
Thanks for this. And thank you really for all of your comments and questions and suggestions as well. I think, first of all, around the research, we need to, and Kerry said that in the beginning, we actually need new ways of researching. And part of that is actually embracing the more emergent theories and examples like realist evaluation, where it's actually, innovation is actually built in, and uncertainty and ambiguity are built into the research approach. But that also means that you need to have funding and you need to have project plans which allow for unknown outcomes, or at least outcomes that are not that precise as you usually need to define. So I think there are a lot of research methodologies out there that we can adapt to for integrated care, which deal with innovation. But a lot of them are very much around being comfortable with uncertainty, and then having that as an innovation and continuous learning as part of your research methodology.
Okay, great. Thanks. And now we're running low on time, so in 1 minute or less, Robin, anything to add?
No, I think that's really important, but I think also this comes down to research funders as well. Research funders have to be willing to put their investments behind emerging innovations, new research methods, and see those as equally credible as the tried and tested traditional ways of doing things.
Okay, absolutely. And I would love to have another discussion about how do we measure these patient experience, and how does that help push forward in our approaches to integrated care? Kay James out there asking that question, but we don't have time. But this is an ongoing discussion, and I think we're making advances. And I've learned a lot from today's panels, from Philiz, Christa, Kerry, Viktoria, Robin, Anne. Thanks for your education. Jodeme, back to you.
So to everyone who is joining us live stream and those that are on the conference portal, a special thank you for joining us today. Listen, we have so much lesson learned, but building on what Kerry said, we created this space together for reflexive learning. I find that in opportunities like this, not only are our panelists being reflexive, but so are all of the attendees. Because we have to build new skill and capability, and to do that, we have to create space to learn together, but not just learn together, learn and do together. And so we're talking about fundamental shifts of learning by doing, creating the enablers to make it all happen, and the fundamental shifts that have to take place for us to address the moral imperative around both the individual person and societal health and well-being, because the ultimate goals around integration is population health and wellness. So two sides of the same coin: partnership with patients and caregivers, and emerging workforce capability. Wishing you all a wonderful rest of the conference. Thank you to our panelists. Such a pleasure, Walter. And now on to IFIC CEO, Neve. So thank you to Jodeme and Walter, and to the fantastic panel that you managed to bring together for what was a treasure trove of perspective, insights, and experiences of integrated care, to add to the very, very many that we've had the pleasure of listening to over the last month. And if I look back at the last 4 weeks, it's almost impossible to pick out highlights. There's been so much content for us to choose from. We reflected in pulling together this conference on our experience of the previous conference, and looking at this virtual conference, we hope that the way we designed this, co-hosted as it was by our country hubs, IFIC Scotland, IFIC Australia, IFIC Ireland, IFIC Canada, and IFIC Latin America, allowed you to get a sense of just how global integrated care now is. We focused the live sessions on discussions and reflections of pre-recorded presentations, and this led, I think, to some very animated and rich discussions of the thorny and complex issues that many of us are facing in the real world of integrated care design and implementation, some of which I think was touched on in the discussion that we had today as part of this plenary. The theme of this 21st International Conference on Integrated Care was realizing the true value of integrated care. This theme follows the publication of the same name, authored by IFIC's research director, Leo Lewis, exploring the ways in which integrated care can address some of the fragility that has been exposed in our health and care systems globally by the COVID-19 pandemic. Whilst the impact of the pandemic was common across our sessions this last month, it has also thrown into sharp relief the difference between different countries in the levels of readiness to adopt or scale models of integrated care. We've been challenged at different times over the last month to think about what integrated care means in relatively resource-poor settings, where communicable diseases still form a huge burden of ill health. Throughout the conference, I've been conscious of the perspectives shared by colleagues coming from settings where resources are more scarce than they are in Europe, North America, and Australia, the locations of our longest running collaborations. We started our conference in Latin America and heard from colleagues there about their journey in integrated care, focusing on shared values and visions. Whilst there's much that's common across the world in integrated care, reimagining more resilient and more equitable health systems is an important aspiration for Latin American countries. And this came through strongly in the experiences that they shared throughout the conference. And for the first time, we had sessions outside of the plenaries conducted in a language other than English. We hope that this is something that will continue in future international conferences. IFIC Scotland hosted an inspiring session in week 2 on health and well-being in resilient communities, something that COVID-19 has exposed as an essential ingredient in the sustainability of all of our countries now and in the future. Thinking beyond organizational boundaries is second nature to integrated care advocates like ourselves, but this approach challenges us to think even further than we ordinarily do. Week 2 was co-hosted by IFIC Australia. The challenges thrown up in the complex and sometimes deeply contested system-wide governance of integrated care were explored both in terms of what we have learned from international research and what they have learned in regional practice. Defining and refining what we mean by value and for whom emerged as a critical lesson. Continuing on the theme of value in integrated care, in week 3, we moved to IFIC Ireland and took a journey through digitally enabled high-impact integrated care, where the feedback loop enables integrated care systems to monitor progress and improvement, ideally with people as partners in their own care. And finally today, in week 4, IFIC Canada have taken us deeper into the importance of making the best out of our most valuable assets in integrated care. People who are partners in their own care and the health and care teams that work with them. Too often in our health and care systems, workforce and people get put into the important to do, but too hard, a problem to solve box. COVID-19 has shown us how invaluable they are and the huge risk we face of losing skilled, experienced workforce, particularly, who've been stretched beyond breaking point by the pandemic. We must grasp this challenge by thinking creatively about how shared decision-making and care. The session today has shared some concrete experiences of this. So, 47 sessions, including poster walks, and this conference has yet again shown there is so much intelligence and insight around integrated care to share. So, we hope that as many of you as possible will join us for our first North American conference.
And co-attending the conference. Why did you make a decision that that was also critically important?
Internationally, we've come a long way in really understanding, appreciating, and respecting the unique experiences and tremendous value that patients, carers, and their families provide. We have a lot more work to do to really authentically come together to listen, to learn, and bring the best of every individual to help us provide better care and better experiences for everyone.
I'm going to sit there. Okay. Tell me about your role in the conference.
One is I have like a nursing perspective, and I can bring kind of my health professional role. And also as a patient, having a brain injury, having struggles in the healthcare system, and not having the resources available to me.
For me, as a caregiver, I would like to contribute my caregiver experiences and what is lacking, what need to improve. I'm a cancer survivor. I also can share some of the insight as a patient.
Jodeme, how are you feeling after that conversation?
Emotional. I'm reminded all the time why we cannot advance any change in healthcare without being connected with the people who experience it, patients and families and their caregivers, because they have the answers. What do you want people to take away?
You can only do it when you bring all those key people together, and this conference actually did that. From its inception right through to presenting the conference, everybody was involved. It was a true co-creation. And so it models what we are aiming to do in healthcare.
And thanks for the people who are participating in that video. We shot that a little bit before the COVID pandemic had everybody recluse. It's actually a little both reassuring and unnerving to see it presented that way with us, giving nice warm hugs to each other. And we look forward, we are on our way back that way. And we really look forward to this year's North American Conference in October. And it's really going to be our last chance to gather together to talk about integrated care before we're next able to be together, as we were showing in that video. The ICIC21 is going to bring the best in the world to gather through our hub in Toronto, Canada. Canada is rapidly advancing towards integrated care models, and Canadians, for example, are among the most populous registrants and presenters at this year's ICIC conference as a nation. Canada is an emerging tide, and the North American Conference on Integrated Care, ICIC 2021, will be a highly connected opportunity where we can see each other and to share our latest knowledge and learnings regarding integrated care. As Neve said, it's amazing how we're advancing, and I think each year so much more. And interim in the fall, we look forward to seeing many of you again. And we're going to have fun. It'll be very engaging and fun at many of the events. We'll have sessions to exchange knowledge with the world's leading researchers, practitioners, planners, policymakers, and patients and caregivers. The conference is co-designed, co-led by patients and caregivers. And we're planning to have panels to match our excellence shown in this year's ICIC conference amongst practice leaders. We're really, really looking forward to being able to highlight this. And we do have a few slides just to run through some of that material. First off, we just want to really acknowledge Jodeme's highlight. We have a moral obligation for population health and wellness, equity, and equitable care for all. And that is our moral imperative. Throughout, our conference themes are going to be highlighting the engagement, meaningful partnerships with patients, families, and communities. We're really keen to be implementing integrated care and understanding what are the roles of top-down policies and the bottom-up innovations, and what are the tensions that are created by enabling integrated care through those two spaces. The transferable lessons in spread and scale of integrated care from around the world. We're looking for all of your participation in really enabling this theme to come to life for us. And also we want to know about adaptive strategies and change management. We talked today in the workforce component about the softer side of integrated care. How do we have those different leadership forms? And finally, to close out the conference, we're going to have a real focus on understanding cutting edge technology and innovations contributing to integrated care. And so we want to know about your latest innovations and ideas and advances in integrating integrated care. And so please get ready to submit your abstracts. The organizing committee has been very busy in the background. Our scientific committee is ready to go. And we're going to give you a little extra time because we want the quality presentations. So we are extending to a final deadline of June 21st, the call for papers. And that will be the end date. We will have chosen the papers to be submitted by mid-July, so that you can be assured that June 21st will be the final end date. But it is a bit of an extension. We want to make sure that everybody has a chance. We are already getting a number of submissions, and we already have registrations, and registration is open as well. So we're really looking forward to seeing you. in October in Toronto. And Jodeme, I'll turn it over to you.
Thank you, Walter, and a warm welcome to everyone who is joining us live and who has registered for the conference. To bring this conference to life, this is the first conference in North America for the International Foundation for Integrated Care, led by the IFIC Canada Hub. We are so excited about the Hub because sometimes in integrated care, ironically, we are not connected up across integrated care systems for learning. And so our goal with the North American Center for Integrated Care is to open up and be connected across North America and with the rest of the globe around understanding the best and most emergent practices to enable population-centered integrated care and to respond to the moral imperative that our global pandemic has brought, which is that in order to reach population level care, we have to integrate our health and social care systems. And most places around the world have not been designed to do so. And so how do we take that leap to build from our strength and to take us where we need to go? Well, the first piece is we have to understand what's most important to people and their families. And Philiz Go has partnered around the entire design and implementation of the conference coming to Canada that'll take place in Toronto. Philiz, along with Carol Ann Alloway, who is a caregiver. But first, Philiz, I want to turn to you and talk about why the partnership with patients and caregivers is so important from your perspective.
Thank you, Jodeme, for the introduction. As Jodeme had mentioned, my name is Philiz Go, and I'm a patient partner. But I also have the lens of a health professional, as I'm a registered oncology nurse, coming from the role of caring for the sick and dying to becoming one who is being cared for and having to depend on others to help me get better and move me through the health system is a humbling experience to endure. I wanted to share this experience and find ways to improve our healthcare system. That is why I approached Jodeme to be part of the planning of the first North American Conference in Integrated Care in Toronto in 2021. It is such a privilege to work with Jodeme, Walter, and the passionate and knowledgeable team that includes Dr. Ross Baker, Fiona Lynn, Miriam Galvin, Carol Ann Alloway, Lily Tran, Vicky Price, Georgina Ferrer, Sally Culford, Reba Silger, Eloise Eldasoro, and Daryl King about integrated care. I'm actively involved in the entire planning and designing of the conference, of which they ensure that they hear my voice. I provide my inputs on the various aspects of patients' needs, accommodations, including the criteria for the call for papers, and how to get patients engaged in a virtual conference. I also contributed relevant topics to address and provided suggestions for keynote speakers from a patient perspective. Patient's voice is central to patient-centered care, and this upcoming conference exemplifies that. Find out more on how to incorporate the voices of patients in your healthcare system. Join us at the ICIC21 Toronto from October 4th to 7th, 2021, and meet people who have the same passion as we do, because we care.
Thank you, Philiz. And for those of you interested in joining us in Toronto, originally this was going to be an in-person session. And our title is Innovation, Inspiration, Integration, Co-Designing for Health and Well-Being with Individuals and Communities. This title came to us as one of the most important shifts because we know for the success of integrated care, we need the foundation in community centered on people and family. And this is pre a global pandemic, and the global pandemic, COVID, re-emphasized our moral imperative to work together to meet the needs, the equitable needs of people and families across our communities. It doesn't matter our geography, the focus on people and family and health and well-being is our moral imperative. And so the conference, although virtual, has now been designed that it's accessible to everyone around the world. We have achieved patients, I would call it patients and caregiver included designation, as Philiz said, And one of the fundamental differences that allows us is if it was in person, our sponsorships would have funded patients and caregivers to come, to have respite care if needed, and to have a fully accessible facility. Instead, today, we have opened up 100% of participation for patients and caregivers to be free all over the world. And that is thanks to the co-design with Philiz and Carol Ann and others, which we know and we heard in our previous session. For us to build the new skills and capability, we have to share power, to learn together, to create space, to build capability so we can deliver on the promise of integrated care that's focused on what's most important to people and families, but also achieve the quadruple or quintuple aim from the Institute for Health Improvement, where it is not just about what's most important to people and their families, although that is the central tenet. It is also to ensure that for all of us who work in health and social care, that we are connected in shared purpose and have a sense of belonging and know that what we do every day is going to make a difference in the lives of people and families because it's focused on what's most important to them. So Walter, I, Philiz, and the entire planning community welcome you to the conference, the very first in North America. We will showcase work that's happening across North America and the globe and bring a collective discussion and learning so we can all bring it back to our local communities. So please join us. We look forward to having you.
Thank you to Jodeme, Walter, and Philiz, getting us all excited for October. And I, for one, am certainly looking forward to being part of that really inclusive conference. We are equally delighted that our 22nd International Conference on Integrated Care is going to take place in Odense, Denmark, from the 23rd to the 25th of May in 2022. That conference is in partnership with Healthcare Denmark in cooperation with Odense University Hospital, the Municipality of Odense, Campus Odense, and Inspiring Denmark. Denmark is among the international forerunners when it comes to integrated healthcare services. So I would like now to introduce Jakob Skarup Nielsen, who is the Chief Executive of Healthcare Denmark, and he will tell us more about our plans for the conference.
Thank you very much. Thank you for the kind introduction. I hope you can all hear me clearly. Very good. Thank you. And thank you for the opportunity to be able to say the closing remarks and do a little PR for the 22nd International Conference on Integrated Care, which will take place in Odense, the fairy tale city of Denmark, the home of Hans Christian Andersen, in May next year. And I definitely would like to come to Toronto in October, and what better would be to follow up with a spring visit to Odense in May of next year. I will touch upon 3 short points for the next few minutes. First of all, I will say just a few words on Healthcare Denmark. I'll say a few more words also on an introduction to the Danish healthcare system, and lastly, I will say a bit more on the themes of the 22nd Integrated Care Conference, which will take place in Copenhagen. Now I'll just check if my app here is working so I can change the slide. Yeah. So first of all, Healthcare Denmark, we are a non-for-profit public-private partnership. We are honored to have the Royal Highness, the Crown Princess of Denmark, as a patron for Healthcare Denmark, and she's very actively involved in our work, and we hope she will be able to join us for the opening ceremony of the Integrated Care Conference in Odense. And yes, I think that's what I want to say about that. Okay. For those of you who are not familiar with the Danish healthcare system, I'll just tell you a little bit about the basic features. The Danish healthcare system is based on 4 fundamental pillars. First of all, it's a public healthcare system with universal coverage. It's based on the principle of free and equal access. It's financed by general taxes. Actually, 84% of all expenses of the Danish healthcare system is paid by taxes, and 16% of out-of-pocket costs typical for medicine and primary dental care. What is also central, fundamental for the Danish healthcare system is a high degree of decentralization, and that will actually be a big part of the discussion of the integrated care conference in 22. Yes. Some find this statement a little bit provocative, but actually the Danish vision for healthcare is basically stay at home. Don't go to the hospitals. Don't go to the doctor unless you really need it. Through this, we have documented that it is possible to provide better care for the patients. You can so to say to make the patients captains of their own health and captains of their own body, and be part of the solution for in the process, at the same time providing the best possible healthcare for all at the lowest effective cost. So in short, our vision is to keep the patients away from the hospitals and at home as long as possible. It's a system for all. And one example for that is, for example, to educate home nurses to help COPD patients at home. And it is have shown to be a more cost-effective way, but also in terms of quality of care, better for the patient to keep them out of the hospitals. Another way of meeting the challenges is to further develop collaborations across the healthcare sectors. The hospitals and the general practitioners are under the authority of the regional councils, while the municipalities are under the authority of the city councils. So municipalities have responsibilities concerning health promotion, prevention, and also concerning rehabilitations and patient education after the discharge from hospitals. By law, the regional councils and municipalities have to sign a mutually binding agreement on the collaboration between the 3 sectors, and this agreement is signed once every 4 years. In all health systems, crossing sector boundaries is a difficult point in the chain of care. This is also the case in Denmark, when the municipalities take over the patients from the hospitals, when the patient is in need for home care and nursing after hospital treatment. When the patients are fully treated, they are discharged, and if the municipalities are not ready to receive the patients, then the patient have to stay in hospital and take up a bed needed for other patients. I will skip that one. Yeah. This brings me to the themes for the ICIC22. We'll be focusing on 3 themes: personalized care and citizen-centered care, digitalization of health and care, and innovation in health and care. As mentioned earlier, the conference is a partnership with Healthcare Denmark, Odense University, the municipality of Odense, and Campus Odense and Inspiring Denmark. A coherent and integrated healthcare system with a high degree of digitalization enables real-time sharing of electronic data and makes it possible to initiate early diagnostics and address for example, chronic diseases in new ways where the patients are empowered and involved in handling their own disease. Electronic communication and sharing of information enables the different caretakers, municipalities, home care staff, hospitals to support, for example, elderly citizens to stay in their own homes as long as possible. As a result, the patient experiences fewer admissions and shorter lengths of stay at hospitals, and the risk of frailty leading to long hospital admission is drastically reduced. And just a small example of that, now the average length of an average hospital stay in Denmark is 2.7 days. So patients spend 2.7 days on average in hospital in Denmark, and this was for around 20 years ago. This was around 7 days. So we have reduced drastically the amount of days that people stay in hospitals, bring them out, bring them to communities, take care of the patient of home, providing better care and quality for the patients. Yeah. This brings me to just also a little few facts on why we hope you will visit Odense in Denmark next year. Denmark is one of the most bicycle-friendly countries in the world, and we will be hosting the Tour de France 22. So hopefully, when you visit Odense, you will get a chance to bike around the town and visit the Hans Christian Andersen Museum and see some of the beautiful sights. We are one of the most digitalized countries in the world. So it's 5.8 million, a high number of messages. Well, we are a country of 5.8 million. So basically, this means that almost there's a digital message for basically each Dane every month from the doctor. It is not quite like that because there are, of course, a number of people getting more messages. But it's just to say we rely heavily on digitalization to solve the challenges we have in our healthcare system, continue to providing better care, better treatments, while we are having an increased demand. For the demand is endless, and digitalization is a big help in that regard in managing to do so. For those of you who didn't know so, Denmark has one of the oldest flags in the world. We are the oldest kingdom in the world, and so as you heard before, we are quite proud of our royalty, and very much hope the Crown Princess will come to Odense. I mentioned digitalization before. Integrated care are used for a lot of our apps. The My Doctor app and medication card app, they are integrated with the electronic health records at the general practitioners and at the hospital. I myself wouldn't know what to do if I didn't have all the different apps for my own well-being at my smartphone. And lastly, but not least, we are known as one of the happiest countries in the world, and remains to be at the top of the UN World Happiness Index report. I believe actually our friends in Finland are right now #1 on the list. But very much hope you will come to Denmark and come to Odense next year in May. And then if we have time for it, we also prepared a very short 2-minute video highlighting what you can experience in Odense next year in May.
Hi, I'm Jodeme. We are hosting the first conference.
My name is Hans Christian Andersen. Welcome to my hometown, Odense, city of great stories. Now I'll show you what Odense can offer.
Denmark has, over the years, left its significant marks. Danish design, furniture, architecture, food, international brands, and large companies are well known and recognized all over the world. Despite this global influence, one must look closely to find Denmark on the world map. Oops, here it is. And right in the center, the city of Odense is located. Odense has always been a major traffic hub from land and sea, and its history goes back more than 1,000 years. Today, Odense has successfully transformed itself from an industrial city into a knowledge-led city by Odense University Hospital and the University of Southern Denmark. Nyborg is the heart of the Kingdom of Denmark, close to woodland, beaches, motorway and railway links. It was Denmark's first capital. From here, kings and queens unified our kingdom. This is where the seeds of our democracy were planted. Denmark met in Nyborg and still does. Nyborg offers a perfect setting for great meetings, a place where ideas are exchanged, decisions are made. Among the historical sites in and around Nyborg are several beautiful manors and castles. Holkenholm has a history that can be traced all the way back to 1590. The 6,000 square meter large manor is open to the public and is a popular location for conferences and private events. The health sector in Denmark is progressing by leaps and bounds. Several new super hospitals are being built, and we see a huge innovation of integrated care initiatives. These initiatives give the patients coordinated treatments and create efficient processes for doctors and hospitals. Here's a good example. CoLab, Denmark. It's a collaboration model that enables private companies to develop new solutions in close cooperation with public health staff and citizens. That gives companies unique possibilities to develop resolutions in the actual everyday environments where they are to be used, and with cooperation of the relevant patients. CoLab has several departments in southern Denmark. Among these is the Odense department, which focuses on treatment in the patient's own home, rather than in hospital.
Well, thank you very much. And I, for one, am looking forward to being in Denmark, in the nearly the happiest country in the world, seeing everybody in person next year. There are so many people who have made this conference possible, but there are some people behind the scenes throughout the conference who have lived and breathed the conference since we closed our last one in 2020. And I would like to take a moment to thank those people. I'd like to thank Miriam Galvin, Darren Curran, Orla Snuko-Carroll and Fiona Line, who have yet again pulled together an exceptional conference experience together with our event partner, Abbey Conferences. I'd like to thank all of our session chairs who had to prepare for every session by watching all of the presentations and facilitating questions and answers in the live sessions. Many were drawn from our country hubs, our special interest groups, our early career researchers network, and IFIC's own board. And we thank each and every one of them for bringing their own perspective and passion to the discussions. We'd like to thank also the scientific committee for this conference, which is made up of almost 50 international experts, policymakers, and patient representatives from all over the world, and is coordinated by IFIC's Dr. Edelweiss Alasoro. These integrated care experts are part of IFIC's global network and are a key driver of the movement for change. We are very, very grateful for your continued support. And that wraps up ICIC21. I look forward to seeing each and every one of you virtually in Toronto in October and next year in person in Denmark. Thank you.